Okay, good afternoon, everybody. Thank you so much for joining us today for the June Healthy Happens Here webinar. And so just a brief overview, this webinar series is a series of virtual webinars that cover a different variety of health topics, including nutrition, physical activity, mental health, tobacco cessation, and also chronic disease self-management. I'm Candace Schottenlohr, a health educator here with the Office of Community Health and Planning, a part of the Florida Department of Health in Miami-Dade County. And so just a few housekeeping items before we begin. Please know you guys have the capability of having your cameras on or off. We did recently just switch to the Zoom platform as we were using GoToMeeting before. Just kind of wanted to make this a little more efficient, and just know that you guys have the capability to mute and unmute your microphones later on for Q&A. And then also, if there's any questions that you have throughout the webinar, you can add them in the chat box today. So we thank you again for being here. And today's event is called The Benefits of a Multifaceted Approach to Well-Being. And so I would like to go ahead and introduce our speakers for today. And first introducing Ms. Mara Sirkowski, who is CareATC's Vice President of Business Development, and she brings over 6 years of experience in population health. And she also has prior experience as a population health management consultant at USI Insurance Services, and has worked in employer health consulting across various nonprofits, universities, healthcare systems, and private institutions. And she also holds a bachelor's of Science in Public Health and a master's in Public Health and Health Education from the University of South Florida. And she also has a certification in public health through the Board of National Public Health Examiners. And her approach is key to supporting employers in reaching their population health needs and organizational goals. And in her spare time, she really enjoys hiking, traveling, and spending time with her family and friends. And so I also would like to introduce Dr. Konstantina Disopola, who is a board certified medical doctor, and she has obtained her medical degree from New York Medical College, and she's worked in clinical and hospital settings throughout New York since 1995. And she is dedicated to working closely with patients to providing quality care on the path to better health and well-being. And so now I'll turn it over to Mara, who will get us started for today and share the objectives for our discussion. Thank you so much.
Thank you, Candace. And just a quick bit of housekeeping on my end. So I am at the airport because schedules are a little crazy. And so if there is some background noise, I do apologize. Feel free to drop questions in the chat, or just go ahead and unmute if you have questions or would like me to stop and maybe re-explain something. So today, really wanting to focus more on the holistic picture of primary care as it supports an individual's well-being. So we'll talk a little bit about the setting of primary care, barriers we're experiencing in the US, benefits of primary care as a foundation to an individual's health outcomes, how we can integrate that into an employee wellness program, which I think will be hopefully very helpful to those of you on the phone, and then improving access to care. Then we'll speak a little bit about the changing needs of the climate of care in the US and beyond. And we'll have our resident queen, Dr. Disopola, speak to how she supports this in her clinic and with her additional clinician and providers. So as we noted, just wanting to speak a little bit to primary care as the foundation of the care to an individual's well-being. So observations and issues with primary care in the US. We all hopefully understand at this point that it is essentially essential to have a primary care physician. They serve as the gatekeepers into the health system and also can develop that rapport and a few additional benefits, which we'll of course review throughout the presentation. But what's going on with primary care that we feel that we're not adequately meeting those needs of the population currently? So in 2015, there was a study done. Unfortunately, there's not more recent data, but this study at that point had found that 25% of Americans did not have a primary care provider. Due to COVID and obviously the generational differences between your millennials and your Generation Z proportions of the population, we are seeing heightened levels of deferred care or individuals who just don't want to seek out care at the primary care level because they do feel that they are efficacious enough in their own to understand when they need to seek out care, maybe more as a secondary or tertiary, but not your primordial or primary prevention, which we really want it to be used as. So in terms of COVID, we've actually seen 10 million missed cancer screenings to date. And so again, that is an impact not just on the quality of life of that individual, but also on the health spend of you as the employer. Additionally, noting that the age of health is gone. So we say the age of health, what that really means is, in years past, we wouldn't see chronic conditions and comorbidities arise maybe until the 50s, until someone was in their 50s, sometimes in their 60s. And now we're seeing these issues like diabetes, heart disease, musculoskeletal issues, and of course, mental health issues are rising sooner and sooner, sometimes into an individual's 20s, typically in their 30s and 40s. So at the individual level, also the expense and the complications of healthcare induce fear. So there may be some ideas misconstrued about what is covered in terms of preventive care by the insurance provider. Specifically speaking to the ACA, all preventive care should be covered. But there have been issues, where Susie Q's friend Joe went to the primary care physician and he had to get extra labs done and they charged him $200. And, everyone has this horror story or a friend of a friend, who went into the primary care physician's office and maybe were billed inappropriately, and that kind of left a tint or a stain on their idea of what primary care should look like. And then additionally, oftentimes individuals are scared of what their physician will tell them. You might be at risk for obesity or for prediabetes. Sometimes we find that in the human error, individuals might feel that it's less scary for them not to know that, and they just kind of avoid and ignore it rather than addressing it, understanding that no matter what, that is the situation that's coming to fruition. Excuse me. And then also right now, we're actually seeing a shortage of primary care physicians in the US. So the data reads that between 2018 to 2033, there is an anticipated range of 21,000 to 55,000 primary care physician shortage. And what that means is, we don't have these physicians who are able to deliver the care, but we are seeing an uptick in mid-level providers, being your nurse practitioners and your physician assistants. Those individuals still need a primary care physician who is an MD or a DO to oversee and collaborate on their care. So, honestly, at any angle that you look at it, that's an issue. So what are the benefits of primary care? I can tell you, I had actually a virtual visit on Monday with my provider, and we talked for like 40 minutes. And we talked about everything from my stress level and different ways that I can, support my mental health, all the way down to, hey, I know my BMI looks elevated, but I work out a lot. Do you think it could be my muscle mass? So understanding that it's good to have those kinds of conversations and establish that rapport builds that baseline of me being able to look at my biometric data from 2022 all the way back to 2015 and understanding what is changing in my body and whether that's indicative of a greater issue or if that might be something that's just more normalized to me. Navigating the healthcare system. So again, this can be an issue for pretty much anyone. I've seen comments, Gallup did their 2021 survey of the status of healthcare in America. And one of the comments was, you need a PhD to be able to navigate healthcare in America, which quite honestly, yes, at times it does feel that way, and especially for the lay individual. So when it comes to that, the primary care relationship is something that will support that individual in navigating, I'm having pains in my stomach. Does that mean, is it actually related to my gastro? Do I need to see a specialist? Can we handle this in office? Or is that pain in my stomach actually something perhaps in my ovaries and I need to go to the GYN? So helping them navigate the clinical system in that way as well. And then of course, preventive care, care plan adherence. So we want to ensure that individuals are seeking out the appropriate age, gender specific cancer screenings, the appropriate blood screenings, the appropriate diagnostics that need to be done to ensure that they are preventing and addressing any chronic conditions or other issues as they arise. And for those members who maybe already have a chronic condition or a comorbidity, that we're actually establishing a plan for them to be able to address those issues and mitigate any kind of complications that might occur. So prevention is the foundation. I put on my public health hat here and got a little nerdy. So primary, secondary, and tertiary levels of care. This is how we address them. All of them can be addressed in a primary care setting. Just because it's tertiary does not mean that it always has to happen at a specialist. So in terms of primary care, primary preventive efforts, we go through family history. We support increasing the knowledge, skills, and the self-efficacy of an individual to understand, address, and recognize some behaviors that might be healthy or maybe that are not healthy, and how can I change those? Lifestyle management resources. So again, there could be a referral to a registered dietitian, or there potentially could be just discussion in the office and resources provided on my plate and how to eat healthy and how many fruits and vegetable servings should I have, and you know what, the potato is not the villain here. Those kinds of conversations. And then in looking at secondary, again, biometric screening, your age, gender specific cancer screening. So it is up to your primary care physician when they're practicing at the absolute best edge of their scope to be recommending and ensuring that their patients are receiving a mammogram on time, that they are doing their pap smears, getting their colorectal screenings when they're supposed to be. So again, these are all occurrences that should be addressed within the primary care setting. And then looking at tertiary, so again, when we engage members who already have a chronic condition or maybe who are in a pre-diabetic state and we could reverse them, we want to ensure that we're reducing the likelihood of complication. So this can be with the primary care physician, and it results in not only enhanced quality of life for that member, but it also results in a significant savings for your health plan when you are avoiding potentially a high cost claimant. Again, as we noted, chronic conditions, quite a few of them can actually be reversed. You might always have that diagnostic code on your record, but through lifestyle modification, we can reverse them and improve that patient's quality of life. And then, of course, that primary care physician can manage referrals as well. So this one's kind of fun. As Candace noted, I did some consulting in prior years. And so what I really love about consulting for the employer workforce is you're able to leverage the captive audience. And what that means is typically an employee in the US spends 80% of their waking day at work. And so being able to impact their environment, even if that's at home now in a virtual world, being able to give them the knowledge and skills, awareness, incentivize them to create healthy behaviors is something that is so important. So kind of starting from left to right, going from your more baseline to more complex programs that you might see in the workforce that can support primary care engagement and well-being. Of course, you have your wellness programs that are, education and awareness, providing resources, providing reading materials and knowledge-based structures. Then maybe adapting your policies to implement a healthy vending policy. The airport here actually has something called Farmer's Bridge. I've never seen it before, but they have these really amazing jars of salads with chickpeas and feta and all of these grilled chicken, which is something that you could absolutely implement in your workforce, just based on your budget and what your goals are. Also, promoting a culture of well-being, supporting things like wellness walks, supporting things like taking a mental health break, logging off of Zoom, getting off of your chair every once in a while. Those are all things that can implement that can impact the individual's well-being. And then moving into programs, so participatory programs and incentives. A best practice for a kind of feel-good wellness program is to say, if you do this, I will award you with this. And so what that means is, specifically in the primary care space, if you go to your primary care physician and get this form filled out that says you went, I, as your employer, will not look at any of the data. I just want to make sure that you went and you were seen and you were talked to and you were touched by a physician. I will give you a premium differential. So I'll take $40 off of every month of your insurance premium, something like that. And again, it's participatory because the only action that a participant has to take is an action. It's not weighted based off of metrics. And so that, plays directly into the annual physical requirement. We would recommend, of course, that data is collected, but typically your carrier or a third-party vendor would be able to manage all of that data and aggregate the reporting for you. So then looking at our next phase, additional components to care requirement. So what that might look like is, okay, for 2 years, you guys have been getting your annual physical, and that's awesome. I would also like you to go get dental cleaning, and let's get that attested by your dentist. It would also be awesome if you could fill out 2 age gender specific screenings. Maybe your mammogram, maybe your PAP. If you're not eligible for a mammogram, your doctor just signs off and says, she's only 30. She doesn't need this yet based off of her risk factors. And so that would be adding additional components. And then at the last phase, we're looking at a health contingent program. So what that essentially means is you're asking participants to attain a certain level of health to be eligible for an incentive. Now, in this, it gets a little sticky. There has to be a reasonable alternative for individuals who maybe don't reach that level. So for example, if the waist and weight is part of your health contingent program, you might say, well, females' waist measurements have to be below 35 inches. And say mine was 36. So instead of telling me, sorry, Mara, you're too big, you can't get it, what you'll say is, you know what, you're not at the appropriate range right now, but we believe in you and we want to support you. So if you complete this healthy weight challenge, or if you complete this, visits with your registered dietitian, we'll give you the incentive. And so that's kind of what that looks like. All right, so we've really kind of set the stage here for the current status, historically what has happened, how we can influence this in the workforce. But now, again, I think COVID shined a really heavy light on the fact that things are changing, and they're changing very rapidly. So we want to address a little bit more about what those changes look like and how we can engage them. All right, a super wordy slide, and I apologize. So, the main takeaway here is that COVID has accelerated the issues specifically of mental health and the chronic condition burden. So high level overview, even prior to COVID, 25% of, or 40% of adults in the US have more than one chronic condition, and 60% have one chronic condition. So again, speaking to quality of life, having a chronic condition heavily impacts that patient and that person's life because of their activities of daily living, discomfort they might feel, pain management, and also the cost to them. How expensive is it to upkeep and manage this condition? The same applies to your health plan. So when we see these numbers increasing, we realize that something's got to give. In addition to that, obesity, of course, is an issue. Almost 50% of participants in a recent study said that they gained weight during the first 12 months of the pandemic. And then let's see, a large percentage of Americans reported skipping care. This is based on the Gallup survey, because of the cost of care had tripled. 30% of them said that if they needed access to quality health care today, that they could not afford it, which is really, really sad. And then because of those things, I'm feeling heavier. I can't afford to take care of myself. Well, it's pretty intuitive that anxiety and depression are going to increase as well. And I think that these have honestly been issues for a while, but one of the silver linings of COVID is that it's become more friendly to talk about them. So we've seen an increase not just in the US, but worldwide. And then again, pulling it back into chronic conditions, 28% of the population with 3 or more chronic conditions attribute 67% of the spend, as compared to those who don't have any chronic conditions, take up 10% of the spend. And you want those who don't have any conditions, of course, to have a little bit of spend. So they're at least seeing their primary care physician, they're seeking out a level of care. But 70% of the spend for less than a third of the population is obviously disproportionate. And then with that, I would love to just introduce Dr. DeSepala, who will talk a little bit about how CareATC has recognized these issues, and we've created a solution that includes the clinicians that you'll see on your screen here, led by an awesome provider like Dr. DeSepala. So I will pass it over to you, Dr. D.
Well, thank you very much, Mara. That was a really good presentation and very nice slides, really targeted to what we are, looking to convey to our audience today. And actually with every slide I was trying to sort of make comments because there's really so much to say. First, I want to start with just thanking Candace for inviting me to be a part of this conversation today, because it's an important conversation, probably one of the most important that we can have with regards to the status of healthcare. I want to say worldwide, but we'll just keep it here within the United States. But first, let me introduce myself and a little bit of my background really quickly. I've been practicing medicine since 1991. I started in the emergency medicine field, a field that I enjoyed tremendously. I loved acute care. I had no time for chronic care medicine. I liked when people came in and we took care of things, whatever it was. It could be a migraine headache. It could be, you cut your finger. It could be a heart attack. It could have been a stroke. So whatever it was, there was a solution and we took care of it. And the reality is that acute care medicine in the United States is fantastic. It really is. We are the leader in acute care medicine. And really where we fall short is with chronic care medicine. That's where we are no longer the leader. We're actually like number 30 in line, which is really quite unfortunate because the acute care setting can only do so much. So, and that's part of the reason, that's part of why I switched over once I was done with my career in acute care or emergency care. I switched it over to a deeper sense of taking care of people. Yeah. So, and this is a very complicated topic, and and where do we begin? Where do we begin? Well, I like to begin looking at, well, what did primary care look like back in the day? I think about primary care or family care when I was a kid, for example, growing up in New York City. Every family had a doctor, and sometimes those doctors did house calls. A lot of times they came to the house and they knew everyone in the family. It's pretty amazing, right? Because, you get to see a lot of the socioeconomic aspects of disease at that time. So that was where primary care started. You had one doctor who took care of so much. And then as the sort of the financial model for healthcare changed, people went from payments to insurance-based models, which actually happened in my lifetime and very early in my career, where I was trying to sort of navigate and understand the world of insurance. Didn't have to do that much in the emergency rooms, right? We took care of everyone. And the payment was really someone else's problem. But what I've learned over the years is that it really becomes everyone's problem, doesn't it? The affordability of healthcare, and I'll talk a little bit more about that in just a little bit. But just getting back to the evolution of primary care. So when I was in the emergency rooms, I loved emergency medicine when it was an emergency. But the fact of the matter is that so much of what I was seeing, myself, my colleagues, and these are busy New York City, sort of outer New York, institutions, big emergency rooms. We see a lot of trauma, but what we saw mostly, the bulk of what I saw on a daily basis were not emergencies. What they were complications of undiagnosed or poorly diagnosed or poorly managed chronic illness. So emergency medicine became a little less exciting for me. And then the question of, well, what's going on? Well, it depended where I was working. If I was working in inner city, a lot of folks really relied on, clinics, sort of, subsidized clinics where they could get, and the wait times were forever. And with someone who's not feeling well, their only recourse was the emergency room. So there was clearly a deficit with that changeover in the financial model, as well as the changeover from having that sort of go-to trusted physician, right? Now we're sort of thrown into the clinic setting where maybe there are multiple doctors, they're never really the same. They, sort of they come and go, they all cover each other. But we were still within the realm of, gee, when I'm sick and I'm in the hospital, my doctor does come to see me. So there was still that level of connection and trust, even when you were no longer in the doctor's office and you were now in the hospital. So this has continued to evolve to a place where, and I just want to mention, and then there were, so let me just regroup. So when I say primary care, I'm talking about your internists, your internal medicine doctors, talking about your family medicine doctors, right? Which covers a lot of other things, your pediatricians and your GYNs. That's really what I consider to be and what is the primary care, and everything else was a subspecialty. The novel residency when I was going through it was family medicine, and family medicine really encompassed that doctor was sort of the internist, was the GYN, delivered the babies, takes care of children and could possibly take care of your pets too if they had to. And so they were really outside of this New York City and outside the metropolitan areas, and tended to work in more rural areas, very similar to the original primary care doctor, right? So without the label of being a family practitioner, they were family practitioners. They sort of stepped in and took care of everything. And so fast forward, now we have the internist, or we have the pediatrician, we have the GYN, and then we have all of our specialists and now super specialists, right? So you don't just have oncology, which is, the specialty of cancer. You have the different divisions, different doctors. So one will take care of the pancreatic and, all of the GI cancers, and another one will take care of central nervous system cancers and so on, and breast cancers and all that. So, you see how it's even become even more difficult to navigate and really figure out, where do I go? Well, you go to your primary doctor, right? The primary doctor who is sort of the gatekeeper, right? I would say for the past 20 years, right? Sort of the gatekeeper. Oh, this is what's going on. Okay, here's your ticket, here's your referral, and we're going to send you to Dr. A. And then when you're done with that, we can send you over to Dr. B. Oh, and something new's popped up, we'll send you over to Dr. C. And you go back and you check in with your primary care doctor, sort of home base. That's where we're at in the evolution of what primary care is. But the fact of the matter is that we're sicker than ever. We're sicker than ever. We are a very sick, tired, overweight, frustrated nation when it comes to healthcare. And that's really the reality. So the question is the current model, what I just described, the primary with all of the subspecialists and all the time and effort that goes into getting to all of those different, places, the current model isn't working. It's clearly not working, right? In 2019, so right before COVID, I actually gave a talk to a large group of wellness, a hotel chain that was interested in bringing wellness into their, different facets of the hotel world, and having special floors dedicated to wellness, and really what that means, and just trying to create definitions of what is wellness. We know what sick looks like, but what does well look like, or do we even know anymore? As Mara said in her slide, the age of health, what does healthy look like? If our children are sick, or children aren't sleeping, the teenagers are sick, you're in your 20s, we're now seeing young women and young men, presenting with autoimmune diseases and just diseases of lifestyle very early on. So we don't even know what wellness looks like. So where's the prototype? I know what wellness looks like, but what are the new practitioners coming through, the new doctors and the nurses and the nurse practitioners and all of the therapists? what's their standard? So, which is, frightening question that I ask, that I just sort of throw out there. And, and the answer is daunting, obviously. So the current model doesn't work. We're not able, in the amount of time in a primary care office, in 15 to 30 minutes, it's very hard to grasp what could possibly be going on. And because this patient who's sitting in front of me, that next appointment isn't for another 2 months because the wait time is so long. So it's very hard to pull together every facet of a patient's or person's life that's leading to what they're complaining about right now, right? So it's hard to put all the pieces of the puzzle together. Let me just get back to what I was trying to say. I'm completely unscripted, by the way. So I tend to go off on branches. And so if you need to, Mara, just bring me right back down to the trunk and the roots. I'm happy. I'm happy for the lead. So in 2019, 250, and this sort of knocked me off my feet because I wasn't aware of the number. 250, this is CDC, all right, Centers for Disease Control. 250,000 deaths were chronic and potentially reversible conditions. 250,000. Is anyone else responding to that number? Because when COVID came along, and Mara did a whole slide on healthcare, during and sort of immediately post-COVID, if we're even post-COVID yet, we're getting there. What happened? What did we do in the United States when we had 250,000 deaths? What did we do? Well, we shut the whole country down. We shut down transportation. We shut down gyms. We shut down restaurants. No more going to work. Everyone was at home, or hopefully in a safe place. You couldn't even go out for a walk. Certain cities had prohibited even going out, walking. So I'm speaking to Floridians here. Our situation was a little bit different, right? We have so much outdoor space, but most folks were snowed in, rained in, and couldn't even catch a breath of fresh air because of the fear, and also, wasn't allowed. But they shut the whole country down. The country stopped functioning at 250,000 deaths. So my question as a practitioner, as a woman, I think, what about the 250 that died from chronic illness? Is it less important? Is it not as dramatic as the COVID? And I know these are pretty big questions that maybe I shouldn't even be bringing up, but it's still 250,000. And there's reversibility. The CDC said chronic, most of which is lifestyle, right? Poor lifestyle habits, and reversible. There was no reversibility at that time for the COVID. It was, it was very, very dramatic when it first presented. So, so if we responded to COVID that way, why aren't we responding as a nation, as, statewide, as communities, responding to these 250,000 chronic deaths a year? And this is not from hospital, someone's in the hospital and maybe got a wrong med. This is not medical mistakes. This is just disease process that led someone to an early grave, right? Because it was just either poorly managed, or they themselves, the patient, couldn't get a hold of these maladies that really just suck the life out of us, right? So that right there tells us that the current model isn't working. But there's always a silver lining, right? And as Mara spoke to a couple of times, is that, we have lots of programs in place, and I think they're really starting to come to fruition, right? Everything that she spoke about with regards to, and I think the slide was at the employee wellness level, really, things that are going on, and incentives, and different programs, and really what we can do within our own communities. So where you work is a community. employee health is a community of people, regardless if they're 2,000 employees, if there are 200 employees, or if there's just 20. It is a place and a space where, if we're smart enough, we can channel, we have access to groups of people, and we can really make an impact. And I really do love, so I'm getting like the chills, hair standing up on my arms, because it's impact, it's the communication, it's sort of being in your face, healthcare in your face, that's going to make the changes that we need to see here in the United States of America. Because, and we can change. We can change this. This is not, doomsday. There are programs in place, and that brings me really to, the collaborative care model, and that's something that I've been working in for a long time prior to my employment at CareATC. And while it looked a little bit different, the concept was the same. Because at the end of the day, the single doctor, that's old. That's just not going to happen anymore. Too many people, too much disease, and it's out of any one person's control. And so I like to say, and Mara's heard this before, it takes a village. It takes a village, it takes a community, and we have to plant seeds in every little aspect, every corner that we can, where people, I hate to keep calling them patients because they are people, who are sick, can recognize, hey, help is out there. And I just want to speak to one of the last slides that you had up, Mara, with the incentives, at employee, that employers are using, sort of the little tokens or the little gifts that you might get, if you could log in that you went to the gym so many times, right? So these sort of components, right? This is happening at work. And I think the thing that struck me when you were going through the various programs and incentives is that how nice for someone who is working very hard, right? Maybe that single mom, or that dad, as working maybe a couple of jobs, really doesn't have the time for healthcare, doesn't have time to take care of themselves because they've got so many other people to care about, and the financial constraints that happen and all of that, to think, wow, my employer cares if I go to the gym, and I'm rewarded for it. So it's sort of like getting that treat because you did something really good consistently when you were a kid, right? And your parents would sort of reward you. And there's such a positive feedback to that concept. And it incentivizes someone. And we know it works because people do engage in these programs. They engage. And then they start to challenge themselves. Well, I went to the gym 4 days a week. Heck, I can go 5 days a week, I can go 6 days a week, and I'll give myself a day off. So they start to create their own personal challenges within the healthcare model. So that was a really great end to that slide, Mara. I really appreciated that. So getting back to, it takes a village. The collaborative care model really was created, I want to say in the world of sort of functional medicine, which is a very holistic approach to medicine, where a group of docs said, hey, we don't really address everything that goes into wellness. It's like, oh, we look at your blood tests, we listen to your heart, everything looks okay, and you're stressed out, you've got to go figure it out. And we didn't really bring into all the different facets that go into making someone well or making someone ill. And so that was created in the functional. And then the American College of Lifestyle Medicine, which is a very profound community of doctors, nurses, practitioners, are working tirelessly with implementing collaborative care models at the hospital level, at the sort of the clinic level for those who don't have the economic means or can't afford insurance on their own, and don't receive maybe insurance through where they might be employed for various reasons. They're teaching the collaborative care model to medical students and nursing students and students of pharmacy, really understanding. And what this collaborative care model does is it creates the medical village for each individual, or for families, entire families. So, and it addresses all of the needs that I just spoke about that are really had been overlooked for such a long time. It really had come down to, it was a time where it was really assembly line medicine. Oh, your cholesterol's high. Well, here's a pill for that. Without really understanding, well, why could it be high? Maybe because this person is working, 2 jobs and going to school and really eats from a vending machine, right? So, the collaborative care model looks into all of that, and that's what I love, and that's really what I do with my patients here at CareATC. Try to get a good understanding of what is your life, at work. We know what your life looks like. If you're working, in the city within the different departments, I can sort of imagine what life looks like. But what about the rest of your life that really impacts everything? And I'm able to ask all of the questions, deep questions. And I think sometimes patients are a little taken aback, like, what do you need to know that for? And I say to them, because it's an important part of who you are, and everything that you tell me has everything to do with why you're not feeling well. All of it comes into play. And when we address it that way, we show respect for each individual, because when someone comes seeking help, they want and they need to be the most important person in the room. They really do. And that's really the start of it. So when we have a model, we have a collaborative model that says, hey, you're really important to me, the doctor, but you know what? Your diet stinks. It's not good. Because for me, diet is really the start of everything. It's what we do all day long, right? We do it 3 times a day. After breathing and heart beating, it's really what we do more than anything else. And so I'll say, hey, I can't address that for you, but I have someone who can help you. So I'm going to send you over to our dietitian, a nutritionist, who's going to work with you on a diet that really addresses what it is that you're going through. Oh, and when you're done with that, you're saying you're always stressed out. We have another practitioner, right? We have a mental health counselor for you that you can sit with, that no one knows anything about what you're talking about with that person. And that becomes your time. Because everyone, right, even in the best of conditions, deserves to sit with an objective, certified counselor who can help you tackle a problem, right? Who's not your best friend, not your mom, not your coworker, who's just going to say what you want to hear. Someone who can really help you get through whatever the issues are, whatever they are. They could be big, they could be small, but they're your issues. So that's important to know. And then, as I consider myself a functional medicine doctor. There's so many other pieces. I like to say we walk around with our stress, and so it really impacts, and a lot of our disease impacts our physical, what I call our physical vehicle, right, from your head to your toes, and that's where sort of the hands-on really becomes very important. So understanding that, your vehicle has to get you right all the way to the finish line, right? To whatever your finish line might be, and how important that is, and how we walk around with that stress. And so, we live lives that really don't honor our posture, what it should be. We spend too much time, leaning forward and, in this position, we're doing this, typing away or whatever, when we really, the mammalian vertebrae, when we think about it, is really meant to go in many, many directions. So if you look at your dogs and you look at your cats, and all the different ways that you can stretch, that they can stretch, we should be able to do the same thing, but we don't take that sort of time. And so we have a practitioner, we have physical therapists and, hands-on, it could be acupuncture, it could be chiropractic, it could be manipulations. But, and the model here at CareATC, we have a physical therapy, and it all works together. So it is such a successful model. because what it does, as I said, number one, it makes the patient, it makes the person feel that they are so important and they're valued and we care. And we care, and that's really the bottom line. If they're just another number or they're just another diagnosis, they're lost. They're lost into the system. I mean, who doesn't want to be the most important person in the room? And so here we have a model that sort of hugs them, right? It makes them feel secure. And so they develop this trust relationship, going back to that original doctor that we talked about, who walked in your house and maybe grandma made a little meal for, kind of thing. It might not be that, but there is that trust back. And so while the doctor, right, or maybe the nurse practitioner, or the physician's assistant doesn't have the time, we have other practitioners that do. And we make it easy for them. We facilitate, appointments. Oh, you too? Okay, we'll make that appointment for you. Don't worry about it. You can't make it, you change it. It's not a big deal. So we don't reprimand people when they can't make an appointment. I mean, unless you miss, all the appointments. And then that's a different story, because there has to be some accountability here too, right? So we can bring the resources, the reminders that Mara spoke about, hey, by the way, have you been to the dentist? Oh no, well, you really do need to get to the dentist. Did you get your eyes checked? Did you make sure that you brought your mother to the, so it becomes sort of a family affair. So, that is really so important. And just, I'm sorry, Mara, you were saying something?
Well, I was just going to note, so of course this is right what we offer in our clinics, but I did want to know, we understand obviously that not every employer has the same budget, or not every employer has the same goals. And so what you're seeing on your screen, just like we talked about, you can integrate these components in your wellness program through your health plan, by advocating for physician attestation for maybe a chiropractor visit, or even incentivizing, and plan design by waiving the fee for the first 10 chiropractor visits, or engaging with a solution provider who offers behavioral health services. So of course, CareATC is a great solution that we believe in, and this is an amazing program, but of course there are ways that you can engage each of these different components through your employee wellness program. And these are the best practice kind of disciplinary areas that we have identified: MSK, behavioral health, dietetics and nutrition therapy, advocacy, which kind of falls into the care coordination piece, to navigation advocacy. And so again, when you're looking to create these programs, these are areas that you should try to investigate. And I would encourage you to talk to your employee benefits consultant, talk to any partners that you have who can offer these kinds of services.
That is a very good point. And to that point, I just want to add that many large universities are incorporating and creating sections of integrative care. It's called integrative care, which is really the collaborative care. And I know, and I'm speaking to folks in Miami, I know the Osher Center for Integrative Medicine, University of Miami, and I go to their conferences every year. I'm a big supporter of Karen Koffler, who's a colleague of mine, back from, when we trained in the integrative model many moons ago, is the leader there. And they do a wonderful job at integrating everything right here on your screen, and more. And more, and saying, hey, let's put a call into your kidney doctor, because sometimes communication is lost just in between practitioners. So it really, and so that model, myself, Dr. Koffler, for example, at the Usher Center, becomes the new gatekeeper. We're tight gatekeepers. We don't let anything through. we make sure nothing really, nothing slides under the gate, right? Without being so, because people rely on that. People rely on that. We have to do for folks what they can't do for themselves. And that brings me to the point where, we can do, but education is really so important. And we're in the world of webinars. And I can't tell a patient something once. They won't believe me. I have to repeat it over and over and over again. And then I ask them to dive in, and I have to show them, oh, you lost 5 pounds. Oh yeah, your knees feel better? Yeah, they feel better. Of course they feel better. Okay, well, what happens when you lose 10 pounds? So it's that trust relationship, it's the education, which is so important. Some days I think we need to educate the doctors again. The doctors and the nurses, especially the old timers, they have to understand a big part of this is getting back to that 250,000 folks that die in the United States from reversible disease. It's not just the patients that have to understand that their disease is reversible. The practitioners have to understand and work with it, and work with what's in front of them and explain that lifestyle works, diet works. In this world of Big Macs and big Slurpees, we are so nutritionally depleted. We are so undernourished. Our bellies are full, right? Our bellies are full, but we're not nourished. And that is real. I mean, I don't want to get into that. That's a whole underground or foundational as to why we are so sick. So I like to just drop the mic after that for a few minutes.
She's like, and that is it.
There's really so much more, so much more to say, right? And then there's complex pieces to the collaborative model. If you live in, I consider myself a New York City doctor, New York doctor. I'm comfortable here in Florida. Would I be so comfortable in Alabama treating the community there that maybe has a background that I'm not familiar with? The same with a doctor from, let's say, North Dakota coming down because they want the Miami lifestyle and not understanding the ethnicities of South Florida, what makes up the people of South Florida, where they're coming from, what their diets look like. That's important. Diet is important to people from a cultural perspective. So understanding all of that, understanding the fears of a culture. They have certain fears with regards to modern medicine and technology and medications in general. Well, you have to have trust to be able to, you have to build that trust relationship. You can't just say, oh, just take it. I took it. That doesn't hold any weight. Like, oh, I took it. My mother took it. Like they're thinking, oh, the doctor took it. Well, it's got to be okay. But it's not. And we don't want to pull one over on people. We really want to present them, educate them, and let them, and let them see that there are so many alternatives out there. And the approach doesn't have to be, you do it my way or the highway. You have to take this medicine or I don't want to see you. It really has to be more encompassing than that. It really has to be gracious to some degree and respectful, because at the end of the day, everyone has the right to decide what they want their health picture to look like, in their health journey. So, that's a lot of the more complex and more detailed aspects of the collaborative model. But, at the end of the day, it works. It is cost effective, which is very important because employers in general spend insurance dollars, through the roof on illness. So if we can capture everyone early and educate, prevent, identify things early on, and change the lifestyle habits, which is really what we need to lead with. That program of 10,000 steps, it works. It really, really works.
Thank you, Dr. D. Sorry, Dr. DeSepolo, we are coming up on time. You are an amazing resource of knowledge. Yeah, you are amazing. And I feel like I've learned so much. I hope that everyone on the presentation has learned a ton today. And I would encourage you again to, if you would love to have a conversation with us and reach out to us, we can talk about this all day long. If you have any questions, again, like specific to your own wellness programs, I'm happy to have a conversation with you, off the Outlook calendar, as I have a consulting background and I just love talking about this and doing this. But I want to pass it back to Candace because I do believe that you had potentially either some questions and you have some slides of your own.
Thank you so much, Mara, and thank you so much, Dr. DeSepolo, for that wonderful conversation and very important and timely related to our well-being as well as the importance of primary care. And so I did want to share, we did receive a question in the registration. They were asking, is this based on someone having health insurance, or will this include those without access to health insurance?
That's a great question. So for the CareATC model, we actually operate outside of health insurance. And this is typically based off of a preference of the employer who they would like to be eligible for the program. But the way that we do it is on a capitated fee model, which essentially means we bill at a per employee per month model. And then based off of that, that employee has pretty much unlimited access. So that means there's no fees for service if they see the dietitian 4 times in a month, or if they see the dietitian 1 time in a year. What you pay is exactly the same. We just want to make sure that we're engaging those members and seeing them and impacting them.
Definitely. Thank you so much. And then the last one that we received in registration, I didn't see any in the chat box for now, but it was in regards to, I guess, just kind of like periodic mental health like checkups. Do you have any insight into, maybe a timeline of how often they should be doing something like that?
So I might defer to Dr. DeSepala on this one, but from my experience, typically there are screenings, right? Like your PHQ-9, that is your approved screening for depression. And typically it's up to your provider, but we would recommend anywhere from, I've seen, every 3 months to every 6 months. And Dr. DeSepala, I'll let you speak to that.
So the question was how often you would see your mental health provider.
Correct.
Yeah. Well, I think that is really going to be determined between the provider and the patient. And that usually comes up, if not in the initial evaluation or meet, obviously in the subsequent. Look, there are conditions that require, astringent, every 10 days or whatever it might be, depending on, what the diagnosis might be. So I think that would be really determined by the skilled practitioner at that point. Mm-hmm.
And I always make this joke, but I could talk to my therapist every single day.
Yeah.
She's probably sick of me as it is. I like text her, but yeah, so it's really up to the patient as well.
Right.
Thank you so much for that. And Mara, I know you had a few more slides. Did you want to speak to any of those?
No, we're okay. We'll give everybody back a minute, and we will send out the deck and this video here. So you go for yours, Candace.
Thanks so much, Mara. And I apologize, the dog is barking. But we'll definitely wrap
dogs are
up.
barking too.
So we'll definitely wrap up. And so these slides will be in the slide deck, but just sharing the Faithful Families curriculum. We're always looking for partners from the faith-based community to really work on these healthy lifestyles and implementing different policy, system, and environmental changes. And so we do have Melissa Mayton's contact information there. And then I just wanted to share on Friday, we will be having a short cooking demonstration, and we'll be launching it through YouTube. And so this is our 8th episode, and the theme is Fix It Fast, Eat at Home. And so we'll be going live at 12 p.m. on Friday. And then lastly, save the date for our next Healthy Happens Here webinar. Will be on understanding plant-based diets, and this will be hosted on Tuesday, July 26th at 1 p.m. And so you guys will have these in your slide deck. And if there are any other questions, we'll definitely be happy to take those and send anything after this webinar. So thank you all so much for joining us today. We greatly appreciate it. Have a great day, everyone.